There's a secret world just outside the hospital walls where clinicians trade stethoscopes for startups. If you've ever wondered how someone goes from seeing patients to building the future of healthcare, you're in the right place. I'm Kayla, a PA on a mission to figure out what comes next. When I started researching careers in health tech, I found confusing job titles and zero clarity on how clinicians actually made the transition. So I went straight to the source, the people who already did it. Each week, we demystify a specific career path by someone who's already living it, whether it's from the bedside to the boardroom, the startup, or something completely different. Whether you're planning your exit, passively curious, or already working in health tech, this is your insider's guide. Welcome to Corporate Espionage. Today, we have Breanne Kaiser. She is a psychologist and healthcare operations, strategy, and policy leader who doesn't just talk about problems, but she actually builds systems to solve them. Her impact on behavioral health policy and operations have literally been felt by millions of people worldwide through her work with the United Nations, the government, and the World Bank. She's directed teams of over 250 professionals across 20 countries, implementing training for over 15,000 clinicians, all while reducing burnout and improving retention. Now, she's applying her clinical and legal expertise to one of the most pressing questions in healthcare. How do we keep adolescents safe when AI enters the conversation? I'm super excited to talk to you today and learn more about the current landscape of adolescent psychology and all of the advancements in AI these days. It is certainly a minefield out there. So welcome, Breanne.
Great. Thank you so much for the wonderful introduction, Kayla.
Absolutely. So it's really nice to catch up with you. We actually had the fantastic opportunity to meet in person and share some sushi and tea in Vegas at the health conference. So it's nice to see you again.
Likewise.
You have a very unique combination of credentials. You're a psychologist and you are also a lawyer, and you've used that to work on everything from UNICEF childhood trauma programs to now AI safety in youth mental health. So kind of walk me through how you got here and how these two degrees are kind of teeing you up for the work that you're doing now.
Yeah, no, thanks for that. Let's just say it's varied and non-traditional, and I think just as much as my education has supported me, so has working across multiple cultures and contexts and countries. So maybe I'll just pull back a little bit. I studied international human rights law in Australia. Worked briefly at the Inter-American Court of Human Rights, thinking I really wanted to be an international human rights lawyer, and I learned very, very quickly that um, there was a little bit of accountability, a lot of transparency, but in international human rights law, um, we can we can convict a country, if you will. A country can be held accountable for the egregious human rights violations, but there are, in most situations, little to no recourse. So for me, that was only one side where I was very much interested in working on how can we support survivors and victims of these violations. So that was a segue into my career, and just come with me on a little journey because it's too many countries and a lot of education. I moved
I'm
to
all ears.
I moved to Thailand. I was working on a community-based mental health project in Mae Hong Son, which is a very, very small village in the north, about 5 hours north of Chiang Mai, and really looking at working with Burmese refugees who had fled from Myanmar and were now in protective refugee situations. And my specific role was to take the Burmese penal code and try to align it with the Thai criminal justice system, civil and penal, because there was a lot of adjudication within the refugee camp. So again, I was looking at what does that accountability mean? And what does it mean in the context and culture? So a lot of people were refugees from Myanmar, but they were following a different legal system. And that really impacted the services that they could receive and the type of uh, penalties that were imposed for egregious legal challenges. So I moved from there to Somalia, worked in Somalia 2 years doing a lot of community-based case management and legal work. And then I moved over to working on the Arab Spring. So I spent a year stationed in Libya, but overseeing programs in Libya and Tunisia. And really, I was starting to do a lot of case management, a lot of working on child protection, and just found myself a little bit over my head. So went to the UK, did a conversion course in foundational psychology, and then moved back to the Middle East. I moved to Lebanon, worked in Iraq, Syria, um, went back to Myanmar. So really had a varied background. And through that process, I realized I really wanted to go back and do more on psychology, not just have that foundational knowledge. So I went back, studied at UCL, child and adolescent mental health. And my international career kind of came to a close, one, because I didn't want to do more field work, and two, the government of the UK said it's time for you to go home. And that combination led me to move back to the United States. Moved back in 2018, but still worked for international organizations, but really focusing on the intersection of legal, let's say more ethics, compliance, regulatory compliance, and then also, how does that impact mental health programming? So really looking at programming at scale, so developing for and with refugees, displaced persons, conflict-affected, war-affected populations. Went to Afghanistan, back to Libya, spent a year in Ukraine, really looking at building up behavioral health systems, but aligning them with their national health regulatory and compliance, but also looking at bringing in more innovation and working with and for youth. Sorry, that was a very
Wow.
long explanation to um, uh, a lot of content.
I love it. So it sounds like with your legal work, you kind of noticed that you felt most called to lean into the behavioral health aspect of the problems that you were seeing abroad.
Yes, and it was really driven by circumstance, if I'm being completely honest. It was more, I would say, less of a calling and more of I was not seeing the direct impact of kind of some of the regulatory and the compliance when we follow and uphold certain laws. Now, obviously, from a safety and security perspective, it's very apparent when you come down to the personal victim slash survivor, it's not always in favor. And really, what really makes a difference, should a person wish to seek and access those services, is access to legal, access to health, access to security, access to a whole suite of packages that are not always available. And that's what really drove me into that more social service oriented
Yeah,
approach. And that's really kind of where I landed on psychology, because obviously there was an interest, but I could bring in more, I could do more impact for a larger population, which is what I really wanted to focus on rather than one-on-one individual care.
certainly. So you go to school for psychology. Then what
Correct.
happens next?
Then I moved back to the United States and I started working with the World Bank in 2020. I'm still very part time with them. And then still from the United States, I mean, this is now the pandemic. So really working remotely, but still working on mental health programming during the pandemic. It really shone a light on not necessarily the lack of providers, which is obviously one of the most pressing topics, but also the lack of mental health literacy and stigma around accessing mental health. And I think the pandemic, especially in my work with regards to working with children and gender-based violence survivors, it really highlighted that people were literally physically trapped in their environment. So what
Yeah.
happens if you are being in a intimate partner violence situation, or children are confronted with domestic violence situation, family violence, and they are literally in an environment with their abuser? What does that mean for them physically, mentally, etc.? So that really perpetuated and moved forward what I wanted to do. And again, looking at this from a more large scale. So what are the policies, what are the practices, and what are the regulations that can help, again, not just that one-to-one, but large scale, at scale programming? So that's when I started to get more involved in creating interventions specifically for those who have or could develop mental health challenges due to their exposure to trauma.
Okay. So, what do some of those interventions and policies look like?
Yeah, so some of those interventions, just let me give you a couple examples. I worked with colleagues to develop it was both looking at social behavior change and mental health interventions for girls who were impacted by gender-based violence. So really looking at, in this context, it was child in an early forced marriage. So what are the social behavior changes from a community, individual, and societal perspective that you can implement? And when you do have child survivors who are either in early and forced marriages, what are the mental health programmings, both from a preventative and response side, that
Mhm.
adolescents specifically could learn to develop that skill set to be more proactive rather than reactive? So it was addressing kind of their specific mental health challenges that they might be confronted with in these types of marriages, arranged marriages, most often. So it's kind of that dual pronged approach. And then the policy side is complementary, but a little bit more at scale. So in Ukraine, I was developing a behavioral health system looking at community-based behavior, all community-based centers, let's say, where you would have access to resources, community resources, anything from mental health literacy to access to a psychiatrist and psychologist on site, and everything in between, including care navigation. So developing everything from the policies to the service specifications for mental health programming for youth in that context. So there's a varied range of things that I've been doing, but that sweet spot is kind of leading and implementing programs around youth behavior health.
Was a lot of that informed by your initial work overseas as well?
Uh, I- it does and it doesn't. And what I mean by that is when you're looking at, when I use my legal background, it is oftentimes synonymous with access to services. When you have the availability and the right to have that informed consent to access legal services, it's really the same engagement as mental health. Now, obviously, there are different legals and parameters regarding, your age. So, largely, I'm
Hmm.
speaking of those over 18, just for simplicity. But I still see them both as service provision. So, does it inform? It informs the way I think and it informs the way I see outcomes, but it doesn't inform the way I approach access to services. I see them as
Hmm.
being one and the same. Obviously, the service provision is very different, but we're still talking about co designing with communities, co designing with those with lived experiences. We're talking about working under specific regulatory frameworks, bringing in that gold standard, both regional and internationally. So standards could be policies, frameworks, practices, um, UN guidelines, for example. So all of that is the same, and that approach is kind of has informed my work, but I see them very separate, but also very kind of intertwined with regards to a type of service provision and a way of thinking, for better, for worse. I don't always think thinking like a lawyer and thinking like a psychologist are complementary. Um, but because I'm not client facing, I see it as a really good um, combination skill set.
Can you say more on that? Why you feel like
Oof.
thinking like a lawyer and a psychologist aren't always complementary?
Well, let's just give an example, and I want to make sure I articulate this right. Um, and again, there are difference for legal jurisdictions and age, but just for simplicity, your role as a psychologist is to do what's in the best interest of your client. Always, always, always. Do no harm, do what is in the best interest of your client. And that could be escalation pathways, that could be informing on different protocols, providing different types of psychotherapeutic techniques, giving life skills, for example. But you're always defaulting to that do no harm in the best interest. Now, when I think like a lawyer, I am thinking as an advocate. So psychologists are advocates, but they're also framed within kind of more of a scientific evidence-based framework. And that doesn't always account for kind of the social determinants, the lived experience, your community, your environment, your context. And the law, while it does consider it, it's oftentimes very black and white. You know, the provision is 1, 2, 3, and you can kind of see within that what is gray and how you can use the law to refute or advocate for your client. But it's very well articulated to an extent. Um, and when a client wants something, I can advise, but it is really up to the client to lead given the advice. So I advocate for the client and with the client, but ultimately it's their decision of how they want to receive and take on that advice. So it's still in the best interest, and we're still looking at do no harm, but the way that you provide those services is very unique.
Understood. Understood. Yeah, it's in a sense, the psychology allows for more nuance, more art, and the law aspect does not. And I feel like the law, right? It's not necessarily open to interpretation as mental health care would be.
Right. And I still think, I mean, this is very anecdotal. Still think within mental health, there are different schools of thought, right? In terms
Yeah.
of, are we, especially, I studied in the UK and I was largely supporting clinicians, not largely, exclusively supporting clinicians abroad, up until 7 years ago.
Hmm.
And with that being said, a lot of the mental health practices are founded in the United States and Western Europe. Not all, but a lot. So we take those interventions and we kind of supplant them on a community in South Sudan, in Kenya, wherever it might be. And there's a lot of contextualization, adaptation that goes on for those interventions, but they weren't necessarily developed within for those communities. They are contextualized to be used at scale within for those communities. Whereas, so I think that school of thought is a very not black and white, but less nuance. In the United States, it's like we do CBT. We do, where this is the evidence base, this is the foundation model, this is the gold standard, which is great for a lot of people, but it doesn't always look at cultural nuances, different ethnic groups, different religious backgrounds, different social determinants, looking at kind of that holistic. And really, that's where, like, to your point, that's where we start talking about the role of clinicians and their framing. And it oftentimes works, but sometimes obviously it doesn't. It depends on that therapeutic alliance and that relationship that has been established.
Right. Okay. So thinking about going from the role of a clinician to treat one
Hmm.
patient
Hmm.
to where you found yourself to kind of scaling in this more massive operation where
Yeah.
you need to apply frameworks that can apply to hundreds of people
Hmm.
in, let's say, a document. Can you talk me a little bit through the process? Because I think that a lot of clinicians who deliver care have trouble conceptualizing what that might look like in a day-to-day aspect. So I can wrap up in a pretty package. I write frameworks for clinicians to deliver at scale. But like, what does that really look like on a day-to-day for you?
It looks like a lot of things. And let me just give you a couple examples because it's not to your point, it's not a pretty package with a pretty bow. It can be messy and it can be, lengthy and lots of conversations that need to be had. So, let me just take my work with Ukraine, for example. I was with UNICEF, for a year in and out of Ukraine. And I left there middle of last year. So, I think May last year. Um, and there is a robust foundation. There's a robust mental health system. Um, they're scaling and changing some of the regulatory frameworks, but there is a functioning mental health and healthcare system, indisputable. But with the given challenges, there's sometimes lack of access because it's war affected. Um, so it's accessibility. Then you're also talking about are providers available, not just accessible. So a lot of the
Hmm.
similar challenges that we're seeing in the United States. So in Ukraine, I was leading a mental health program. I had one other mental health professional colleague, and the rest of the people were program managers with varied backgrounds. So my portfolio when I started was 800 million, dropped down to about 500 million by the time I left in the duration of that year. So $500 million, and we have two mental health providers for the country. Now, that doesn't insinuate, or I don't want to insinuate that there weren't providers on the ground. But when we're talking about programs, the programs need to be managed, they need to be implemented, you need to do quality assurance. So what does that look like when you have a range of backgrounds, a range of academic backgrounds, and they're all providing mental health care? So at the basic level, it's mental health literacy, doing 1,001 trainings on literally what is mental health and what is a mental health outcome, and how does that differ and vary from a programmatic outcome. An example, art therapy. Everyone's doing art therapy. I visited a couple locations, and children are indeed doing art, and it's amazing. But there was no therapeutic component. It was children playing and
Sure.
children doing art, which is huge beneficial. But there's no mental health outcome in an unstructured way, without discussions, without having someone kind of facilitate a dialogue around that. For example, so a lot of it is looking at what does mental health outcomes programmings look like. And then the flip side is creating clinical supervision. I created a program working with the university in Germany, and really doing the first supportive supervision program for a tier of master's degree clinicians. So really kind of, it's everything in between, really understanding the context. What are the gaps? What are the challenges? And how can a program complement those? So I know I'm not really giving you a very concrete answer, because there's no one answer. My job
Yeah.
in Ukraine varied significantly than my work in Ukraine, or sorry, in South Sudan versus Thailand. It's all needs to be contextualized, and really understanding both the political, the regulatory, but also the community services. What's available? What are the gaps? And really, what is your first point of entry? And what is that kind of fast ROI? Generally, that means large scale, kind of that subclinical approach, with the understanding there are very few who need to access more acute care. But that's not necessarily for the masses. We're just
Sure.
looking at access to kind of coping mechanisms, and those who have potential exposure to trauma. I'm really trying to mitigate some of those challenges that might arise from their specific context.
I think that gives a lot of visibility into what a operator truly does day to day. So thank you. I think that that was a great explanation. I'm interested also in what are some of the biggest challenges to these rollouts and implementations?
Money, time, and I say that kind of jokingly, but um you start at zero and you go to 1,000 in about a week. And of course, there are a whole bunch of processes, and there's a lot of models that are already available. So assuming we're not writing a curriculum, which obviously takes
Sure.
way longer,
Yeah.
but from rolling out to implementation, weeks. So that means developing your proposal, developing all your KPIs, your metrics, and doing all your validation, and making sure the people are necessary. We've hired appropriately and we've trained appropriately. So obviously, in a context like Ukraine, in frontline areas, obviously that looks very, very different than those who have access to clinicians who don't need to be upskilled. So it does vary. The range is vast, but I think it's always going to be money. It's always kind of on a revolving door. So money might come in, and the grant from country X is only available for 6 months to a year. So you might work through 10 local implementing partners for very short-term programs, whereas another donor might say we have a 3-year or a 2-year, and how can we complement existing programs that just need kind of like an injection of cash. But really our biggest challenge would be would be just that. It's time and money, which I think probably is no different than implementation anywhere else.
Yeah, no doubt. Absolutely. So we talked a little bit about ROI,
Mhm.
KPIs. What in the behavioral health space does that mean? Because obviously, we just were present at Health this year in Vegas, and a lot of the focus is on how do we make money? And
Yeah.
I think a lot of businesses don't succeed unless you find the value proposition that is literally financial gain.
Mhm.
Not always positive clinical outcomes, not always the patients are healthier. And it's hard for sometimes investors and I'm sure maybe grant writers to see the value in something that doesn't have a ROI in the financial sense. So, as far as the behavioral health sector goes, what are some of
Mhm.
those ROIs?
Do you mean in global mental health or kind of in the current American landscape? Because I think they're very different.
Let's talk through a little bit of both.
Okay, so I think global mental health, and again, I'm assuming that I'm working under a nonprofit structure or the UN,
Okay.
etc. So I'm not looking at a monetary gain. I'm looking at efficiency from a donor perspective, but I'm not looking at a monetary valuation. So my outcomes are solely focused on clinical outcomes, positive or negative, so mental health outcomes. Now, aligned to that has to be efficiency. So, is the program using the money wisely and well? Are we getting kind of that return on investment? So, if you know, we're if 500,000 people need assistance, uh, uh, your ROI is not 5 people. Now, it could be 5 people for a very small subset, but programmatically, we're not going to help 5 people with $500,000.
Yeah.
So we're looking at efficiency, but we're looking at clinical outcomes almost so focused. Almost. Um, when I trained and now moving back to the American context, I think it's varied. I think fortunately, I do think even VC funded behavioral health companies still do want what's best for the client or their patients. I want to fundamentally believe that. Um, but we're also looking at your drop-offs. We're looking at your clinical retention. We're looking at some of, it's all financial and efficiency. So I think all those workflows and those verticals that support monetary gain are always looked at. How are we maximizing our dollar? How are we minimizing dropouts? How are we retaining our clinicians? How are we using AI, the new buzzword, to improve those workflows to give our clinicians back 5 minutes so they can maybe see another patient or client?
Yeah.
So I think that is important. But at the same thing, the underlining, what I have seen since kind of transitioning or pivoting to the United States is while those are still, we still need to be mindful of kind of that financial liability. Um, I think that sometimes what's sometimes lost in translation is how are we treating clinicians? Because you can make a bajillion dollars for a company, but if our clinicians are not receiving the supportive supervision that they need, they are not, we maximizing clinicians at 32 clients, 35 clients. I mean, it's ridiculous. It's burning out clinicians. And then we are seeing, reduction in workforce, but is the reduction because of a lack of availability or that we're trying to kind of eke one or two more clients out of them so they're at 30 clients a week rather than probably the recommended, I don't know, say 25.
Yeah,
Because it's not just the administrative toll, it's the mental fatigue,
for sure.
the moral injury and the burnout that clinicians are facing.
That is so real. So, what work have you been up to in the States regarding clinician burnout, decreasing administrative burden, and along those lines?
Yeah, so I'm a firm believer of supportive supervision. So kind of taking that clinical supervision approach, but also doing it more in a holistic way where we're actually not just looking at HR. I think HR and having your employees have access to mental health support services kind of writ large is great. But unless we embed institutionally some of moral injury, that, psychological first aid, that burnout
Hmm.
mitigation, um, I so just as an example, I worked with, had a consultancy with FHI, so they're American based, but they work globally. And through my work with them, my first reaction was like, of course, just put it in HR. Just assume that everyone should have access to mental health services, a reduction in
Yeah.
workload if they need it, time off, etc. But, through my work with them, it became very clear that unless the managers are empowered, unless, the system supports actual programs for their clinicians, we're not going to see a reduction in burnout. So I think it's one institutionalization, but also that supportive supervision. So kind of taking that same clinical approach, if you will, but taking kind of the clients out of the equation and really looking at peer-to-peer support. And I see this as kind of part of the company, part of the workday, not excluding. So we're not saying if you do 1 hour of supportive supervision once a month, we're not, saying then you have to make up that client somewhere. No, we're actually
Yeah.
embedding these practices and policies within the institution that you're working with. And I think that's having peer-to-peer support and have it being, having a standing meeting where you can discuss challenges. And again, I'm not talking about mental health support. I'm talking about peer-to-peer support.
Yep.
You have an opportunity to speak with your supervisor. And we also use this time for trainings, access to information, resource, information sharing, but also kind of a coming together from your peers. So I think that having that institutional structure really does support and mitigate some of the burnout. And that's what I see has worked very, very well through the work that I've previously done.
Yeah. I think that the behavioral health side of things does a much better job of ongoing education and ongoing peer-to-peer support and
Right.
ongoing supportive learning than the traditional medical system does. Um, I mean,
Interesting.
personally, in my work,
Yep.
I can receive support with knowledge and my education base when I seek it out, but it is
Hmm.
not generally offered. It is only when you cry for help or only when you ask for support that it is given. So, a conversation I had recently with some really awesome folks who are building in the space is how do we improve clinicians? So, specifically talking about PAs and nurse practitioners,
Sure,
how do
sure.
we improve their access to high quality chart review? So,
Right.
in my career thus far, the high level is that I'm a PA, I'm not a physician. Nurse practitioners are
Right.
also not physicians, right? So we didn't go to med school, we didn't go through residency, we didn't go through fellowship. We have
Right.
much less years of training. And the
Right.
law essentially lays out that I cannot practice legally without the ongoing supervision of a
Hmm.
MD or DO. That is
Gotcha.
on my license, that person's name is
Right.
written down. That person, their role, their features are essentially to be a soundboard for me or to
Hmm.
be a support system for my ongoing, you know, ability to give high quality care to patients. Like that is what the model was designed to do. It is not
Right.
only to protect patients, it is also to keep me on my toes and keep me um, able to access learning and
Right.
access improvement. So the chart reviews that I've had in the past clinically have not been done by physicians. They've been done by other PAs or NPs, which I found out recently is a very common thing. I see a fundamental flaw there. Number two, they can be like outsourced, which that's okay. But they are not done very frequently. So, historically speaking, I've had my chart reviews done about once a year when the
Hmm.
annual review comes up. And it's
Hmm.
like 10 random charts that are picked. And unfortunately, in the setting that I work in, I might see 45 or 50 people in a day. So, this 10 charts could literally be all the same complaint and pretty much the same documentation. And then I'm kind of SOL. Um, but I think improving the ongoing support of clinicians is something that I know now is being talked about more because I am talking to people
Right.
building in that space to make it more integrated, like literally with AI, but with physician oversight,
Yeah.
so that we have that ongoing support. Because I'm not gonna lie, Bran, like sometimes I feel totally lost in the weeds. I'm
Of
like,
course.
I want to call and ask about this thing, but I don't feel supported, or I
Right.
want to do this research, but getting through to a human being is going to take a lot longer than me doing a little up-to-date query and having the information available to me and my patient who's miserable and who wants to go home in 3 minutes or less.
Right.
So I
Right.
think improving that access to ongoing learning, ongoing training, ongoing, like you said, support is really, really important. And I think I've noticed I've gone down the path of considering going for psychology and getting like another degree and being able to practice as a psychologist. And I noticed that as a distinct difference. And I think obviously there's an element of the empathy burnout that is much, much greater for people who practice in behavioral health.
Hmm.
Um, but I think we underestimate the impact of that as well in the traditional medical space as well.
Yeah, no, absolutely. And I think it's anytime, quite frankly, we can even broaden. I know we're talking more about like healthcare writ large, but anyone who is service oriented, I mean, you were just talking, going to a conference and you're speaking all day, you're on your feet. And it's just, that is taxing. And that is, voluntary. But persons who are in the service industry, persons who are engaged in gig work, people who are speaking with others, like that is so taxing on an individual to kind of always be on. When do we get to be off? And especially as clinician, any clinician, I would imagine, I'm speaking from the behavioral health side, but it's just let's just take out all of what we're take out the topical information, and it's just being on is challenging. Because, not every day at work are we, sunshine and rainbows. So I think
Yeah.
to your point, it's really hard. And how do we look at supporting that? And I think that's where we were starting to see kind of training and development. But this is, I mean, the famous AI. How can we? So I see AI as a tool to complement clinicians and to minimize some of the administrative, for example, workload. But I don't see that to add to their load. I see that as two distinct differences. Let's support and alleviate, but that doesn't mean that we reduced 2 hours of
Backfill.
your
Yeah.
workday. Yeah, backfill. So do you see two more clients? I mean, no. For me, like I don't think so. I don't know what your opinions would be on that, but I think it's then we're not still doing a disservice, because your therapist burnout scores are just going to be through the roof because we've just sometimes reading a chart or doing a review or doing your notes is sometimes a small break of not seeing clients.
Yep.
um I don't know if you have any thoughts on that, but yeah, I have a lot.
Yeah. I agree. I think that there are certainly cases where the AI tools that are being used for administrative work are being backfilled. But I
Yeah,
think that the smart companies are proactively having
absolutely.
conversations with their clients, which either are
Yes.
hospital systems or small
Yeah.
practices or small hospital systems, or even individuals, and saying, pushing the overall financial gain,
Yeah.
even just from increased accuracy, increased depth of documentation, the ability to upcode, and making it a point to say that, like, this does not mean that you add another patient to your provider schedule. This means that you are able to retain your person longer. This means
Hmm.
that your person is proud to work where they do. This means that your provider is going to be giving better care on a regular basis. And that's ultimately going to translate to more money in your pocket
Yeah.
from better billing
Yeah.
and improved patient outcomes.
Yeah. No, and I was just sorry, as we're doing this, I was like, I have like a master kind of, metric spreadsheet, and I was just kind of going through it and thinking like how much of it is financial, but the way you've articulated, I'm looking at, I look at revenue per therapist, I look at operational cost saving, I look at, your low patient engagement and outcome assessments, all these things. But to your point, if we actually do more support to retain and to upskill and to provide further learnings, that's where we start to retain, and that's when we start to have
Yeah,
better outcomes because our therapists are more engaged and invested not only in their company but also in their clients.
right. And I mean, the goal of the rollout of these tools, although I think that this podcast is a, beautiful baby that has been born through my personal experience,
Right.
partially is in existence because like I'm feeling the weight of it. And I'm feeling the lack of support and the empathy fatigue and the huge administrative burden that comes from years of service without, you know, any sort of tools to
Hmm.
prevent the fallout.
Right. Right. No, and I think, I'm always reticent to say that I'm a psychologist because I haven't practiced. Now, I've supported psychologists on front lines for years, but, I haven't been a practitioner for a long time too, for
Hmm.
those very reasons. Now, I burnt out on
Hmm.
global mental health for a lot of other reasons,
Sure.
but, it was seeing clients that I honestly passed, the most kind of pressing and um, very challenging cases. I have not seen clients in years for this exact reason.
Yeah. So, on a more positive note, so along the lines of anyone who may be along the clinical path from a social worker to a psychiatrist,
Mhm.
including psychologists, if they are thinking that, like, this is my pain point, I'm really starting to burn out, and they want to get more involved in the policies that are hopefully going to impact the prevention of burnout, where would you recommend that they even start? Like, what do they need to be looking out for? How can they get involved? How can they actually be a part of the positive upswing?
So there's a couple ways of looking at this. One, it's how can you, or how perhaps do you want to make a change within your organization, and how could you perhaps influence other clinicians or other policies, down from maybe a well-being perspective all the way up to actual regulatory frameworks. So maybe I'll start with within your own organization. Um, I guess the first thing is, does your organization have circles of support? Do you have any sort of peer-to-peer support systems? Do you have feedback loops? Do you have kind of the minimum standards in place as an organization? And I say, if you don't, maybe that's a good place to start. You could be proactive. For me, kind of the baseline is a feedback loop system. And that doesn't mean that you are the one initiating and designing. That means you're being a part of perhaps what makes sense from your clinical and personal perspective. And I think that's a very good place to start. The second one is, what is your peer-to-peer affinity circles look like? If you don't have them, can you start one on the topic of burnout, for example? Can you speak to your manager about doing more therapist training, doing more clinical supervision, kind of looking at those? Does your organization actually have a burnout policy?
Mm,
I think now we're starting to, with the ICD-11 when it came out, and obviously it wasn't kind of a clinical diagnosis, but acknowledging that it does actually exist. Does your organization follow some of those guidelines that are already available at a minimum? So I think looking inwards is a great start, seeing what exists and what doesn't, what gaps are there, and how can you use both your personal and your clinical expertise to fill some of those gaps. And I don't think it has to be a heavy lift. And I think especially for therapists, they're already doing the heavy lift of the companies providing behavioral support. They are the front line, full
Hmm.
stop. So I think having those champions within your company are imperative, and they don't always need to be clinicians. Um, by any means. I think sometimes I feel more engaged or more that I should be the person leading all the mental health services. And the reality is, I mean, I'm speaking personally, that will lead to my burnout. If I do more, an additional 10 hours a week, that will lead to my burnout. So it's kind of that push pull factor. And then I think if we're looking externally, looking at, are you engaged in other groups? There's therapists in tech, there's fit minded, there are things available where other clinicians comes together and you can provide kind of those forums informally to talk about these things. But when we're talking about actually changing regulatory frameworks, be engaged with the policies, be engaged with the regulations. Washington is changing very rapidly right now. How engaged do you want to be, and are you following kind of those regulations? And for me, you know I got engaged with Society for Digital Mental Health, for example. So it is um, an academic led digital society with many different special interest groups. So you can engage with one, so it's both looking at both the um, the operational side, the academic side, really looking at a diverse set of individuals where you can start talking about some of these regulatory pathways or institutional norms. So I think looking kind of within your local community, seeing where your interests are, and then if that's not something that you want to be engaged with, looking at outside of that and being more proactive and be engaged in some of, APA, Society for Digital Mental Health, DIME. These are groups
Hmm.
that already exist where you can have a seat at the table to influence some of these norms.
Yeah, definitely. I agree that like the first step really just comes down to pulling your chair up and having a seat, like putting yourself in the rooms.
Yeah.
And sometimes you have to swim upstream to get there, but it's definitely worth it.
Yes. It is. And not to say that it's easy to do, because it's,
Yeah.
sometimes you have to elbow your way into the room. But once you're in the room, you have a seat at the table. So there is so much value in being present in the circles where these decisions are being made, or at least being a part of the decision making process if you can't be in the room.
Yeah. Okay, so I want to talk about one more thing before our
Hmm.
time is up. I know that you are focused now
Yep.
on youth mental health and
Correct.
the rise of AI being integrated in almost every second of our daily lives, and how that is impacting the mental health and the development and the social skills of our youth and our adolescents. And I'd love for you to just sort of tell me more about your work in that space,
I
why it matters to you, and why it should matter to all of us.
um why it matters to me. I mean, it's because I love working with youth. I love mental health, and I love, I'm that regulatory compliance nerd. And this is at the intersection of all of these things. Um, what also freaks me out is, ChatGPT is my coach and probably sometimes my therapist. Like, I will be the first to admit I have a specific question. And it's like, this and then what this happened and what would you suggest I do, or how should I approach? And it's like, I am talking
Great job,
to.
Brianne.
I know. Yeah, exactly. I love
Great
that
question.
affirmation. You're amazing. Great question. And then it like essentially feeds back to me like kind of my voice. And
Yeah.
I love it for that very reason. Now, is it clinically sound? No. Does it need to always be clinically sound? No. But what I see some of the challenges is the distinction between when should it and when should it not be. And when you, like just in the case of youth, and we're talking about why does it matter to other people, kids are using, I'm talking about generative AI, right? Where I'm not talking about the AI agent in, workflow and clinical navigation. So I
Yep.
think these are two different things. But
Agreed.
if we're looking at kind of the LLMs, kids are already using it. Like, we can do age insurance until you're blue in the face. Kids will get around that if they want to. That is a fact. Now, do I think that we can put different protocols and policies in place to minimize access? Absolutely. So, obviously, those safeguards are super important, and we always want to look at risk mitigation. But the reality is, okay, you don't use cell phones at home? Great. You're going to have access to a computer at school, or you go to a friend's house. So I think living in the reality is children, youth are already accessing these tools, and they are already using them in a huge, varied situations, anything from I'm getting bullied to like what color lipstick will look good with this outfit. I don't know.
Yep.
Um
Yep.
but I think we can't minimize how much kids are already turning to these systems. So the reason why it should matter is because it does matter that there are limited frameworks in most companies, not all, where there are trust and safety teams. There could be compliance where we're looking at FDA regulations. Is your software used as a medical device, for example? So that like changes the clinical approaches and the regulations. But if we're kind of looking at OpenAI, there is a trust and safety team, but my question then to them is how many clinicians are about? How many therapists are dictating your user policy?
Mm-hmm.
How much prompt engineering are you doing around mental health, around
Mm-hmm.
youth mental health? Who is overseeing those those escalation protocols and pathways? Are your moderators engaged? Do they have the learnings and the understanding around mental health before it's kind of goes up the chain? Do you have those processes? And then kind of the tertiary would be, escalation to a clinician. I was on a talk, or I was listening to a talk a couple weeks ago, and there was a large company that just came out and they said, we do AI therapy. I can't remember exactly the phrasing, but it was like, this is your AI therapist.
Mm-hmm.
And they said very proactively that that would be the ideal situation. We need to have the escalation once, you've been flagged for ideation, for example,
Yeah.
disordered eating, self-harm, whatever it might be, that it goes to a clinician. But he very clearly stated that it's egregiously expensive. So while that's the ideal, it's just as we sit today, time and space is just not feasible. Not to say that it won't be feasible later on. So now we're looking at developing those policies and escalation pathways internally within these companies so they can discern the specific challenges and response. Is that enough? I mean, that gives me pause to think of that system itself. I see clinical's overview and insight into these processes as part of trust and safety, but very distinct. Um, so I think both are needed, but you can't have these protocols in place if you have a handful of mental health practitioners and experts in the room when we're talking about a user base in the hundreds of millions.
Right. Do you know if let's just keep it simple and say like Claude, Perplexity, ChatGPT, do they have escalation protocols right now if a user has ideation or intent or plan? They do.
They do. They do. Um, we can talk about efficacy of those protocols,
Sure.
but absolutely. But then we take the case, and we know I need to tweak this a little bit. Adam Rain. Adam Rain was a child who was in California and very unfortunately is no longer with us, died by suicide. And there was an engagement with ChatGPT for over a protracted period of time. And during that process, there was a lot of back and forth of, I want to, I feel bad. I want to tell my mom this. And ChatGPT was, to your point, we're going to validate you. You know what? That's not a good idea. Let's just keep this between us. And of course, I am parsing this awful, awful situation down. But the reality is, he talked about ideation hundreds of times.
Yeah.
ChatGPT then fed back the information 6 times more prevalency than Adam was providing to them. So that's 6 times higher engagement from ChatGPT rather than Adam Reed. And really, at the end of the day, when he was uploading pictures of self-harm, they weren't flagged. So the protocols 100% do exist. I know they exist. Obviously, I can't comment on the quality, but it's not foolproof. Is there a way to make them
Yep.
foolproof? No. But what does that mean otherwise? Then I come back to literacy, engagement. Are we designing with youth? It's great to have a youth sounding board, but having 10 youth on a global platform is not going to cut it. You need to have youth in different cultures, contexts, religions, a whole bunch of varied backgrounds. And, a representative sample size is not 10 people for hundreds of millions of users, for example. So I think designing with clinicians and designing with youth is more imperative than ever.
Wow. Obviously, we're in the early stages of this technology, and there have certainly been plenty of iterations of other technology that becomes an echo chamber for anyone who is in a bad state of mind or is having ideation or intention or even acting on, mental health struggles. But I'm curious at what urgency we will move to implement safeguards in the world of AI, because it feels like if we are running at the speed of light, why can't we also run at the speed of light for this thing that really has real world impact?
Yeah. Government and money? No, I mean, look, I think there are safeguards in place at a minimum. Fundamentally know that to be
Sure.
true. And especially when we're talking about the era of responsible AI. But risk mitigation and safeguards is not 100% guarantee, nor can it be. So for me, the question is, how robust are our safeguards and
Mhm.
our risk mitigation practices?
Mhm.
Um, and they will look, again, very different from a trust and safety perspective, which of course includes mental health. But when we're specifically looking at mental health, those safeguards are similar but distinct from trust and safety. So, I mean, to your point, at what point does it become an issue? Well, aren't we there? Like, in my mind, like we're there. We've passed that moment. It is imperative. Um, Especially as we're talking about, the isolation epidemic and people being more engaged, more proactively engaged with some of these devices, the apps, etc. Um, I think the government is starting to make strides towards that, but it's yet to be seen how regulations, especially opt-in regulations, will actually be implemented in practice.
Mhm.
That's yet to be seen. Okay.
What is the work that you're doing at this moment in time in this space?
Yeah, so I will just need to expand it a little bit. So I'm working with one startup doing, let's say, data and AI in the behavioral health space. So really looking at how can data inform longitudinal outcomes. And you can look at that in a whole bunch of different ways, but part of it is looking at safeguarding. So it's really, let me scale back. It's really looking at what specific metrics do you already have, and how can your real world data inform through synthetic and other real world data applications, kind of your current clinical practices. So it's taking kind of your current system, adding some other variables, and saying these are some longitudinal outcomes, both from the clinical side, but also from the safeguarding side. I'm coming in on the behavioral health side, and that's what I can speak best to. But what our team does include AI engineers, prompt specialists, etc. And then I'm also advising a nonprofit on kind of their overall strategy, looking at specifically around, I know it goes back to kind of that funding question, looking at how can we synthesize and strategize, while also kind of holding true to our core tenet, which is better outcomes for mental health. Um, and then the third, I actually just exited. They pivoted their company, as a lot of startups do, from youth mental health, now working more on the NP side. So originally I was working on protocols, youth kind of interventions, subclinical interventions, peer-to-peer support with them, and developing those protocols and
Mhm.
interventions with them as well.
That's a lot.
It seems
You're
like a
doing a
lot.
lot.
Seems like a lot. And then I get to go to St. Martin with the World Bank in November. So, which is nice. It's like work vacation, if you will.
Yeah.
So, it's nice to keep them around. Or let me rephrase, it's nice that they keep me around.
Fantastic. I love that. That's a really nice added benefit.
Yes. Yes.
So, did you have any inspiration from the conference at Health, or did you hear of any new companies that are really mission driven, doing really impactful work? I'd love to hear more about like where you think this problem is headed and what are some of the solutions that are being built to tackle it.
There are, I mean, personally, it's hard for me to reconcile only financially driven companies. I thought in the beginning of my transition, like I love money. I thought it'd be totally okay just being 100% part of the capitalist system, which I am. But then I realized I still personally need to align more mission driven. Um, and I will say there are a few companies that I've had my eye on and got to meet with a couple founders. Um, that are mission driven, clinically oriented, but also financially motivated.
Yeah,
Um,
fantastic.
and I think that trifecta is kind of what keeps me going. It's also kind of an inward look of what can work for me and what doesn't work for me. And when I started, a year ago looking at this, I thought 100% every company that does youth behavioral health, I'm aligned. I thought like this is golden. I can go anywhere. But the reality for me is that of those, I don't know, maybe 15% or maybe mission driven. And that's what's important for me. That we treat our clinicians well, that they are the frontline workers. And if a company does not support that, personally, that's not the best fit for me. So what motivates me is to work with companies and people that are mental health minded and focused, but also looking at those clinical outcomes. And again, I'm not always saying you need to have like a treatment adherence or, my gold standard is not always patient symptom reduction. It's just access to good quality care. So that's kind of where I'm sitting. That was my biggest takeaway from health is kind of figuring out where I can sit and do sit and where my values align with other companies.
Are there any other tools that you've seen being developed right now that like particularly excite you in the space?
You
Even if
know,
you don't name drop them and just describe their concept?
yeah, that's what I was trying to do. Yeah, yeah, yeah. So I think there's one company, and again, it's not necessarily, I didn't find it super innovative, but just super, super well executed and smart.
Sure.
Um, his company is basically, for all intents and purposes, like a case management company. So really looking at the whole self. So you are, you're coming to seek out mental health treatment or primary care, whatever it might be, but maybe you also need access to, maybe you're facing food insecurity, or maybe you have a family member with Alzheimer's. It's really looking at that full support system, like a very traditional pen to paper case management system. And I thought, gosh, that's just smart, taking that traditional PCP
Mhm.
kind of 1950s model, if you will,
Mhm.
um, and really kind of operationalizing it using AI, using care navigation. I think that's just smart. It's just smart. And I think for me, when I see something go beyond collaborative care, but actually more into and past value-based care, but into more of, again, supporting the individual, their full support system, that's where I see that is what I would call innovation. I also, there are a couple companies that I think are moving not towards, but kind of leaning into kind of like subclinical coaching. So kind of a pocket coaching for patients, for clients who, again, are not seeking or don't need access to a therapist, but they just kind of need a chat buddy, or they just need a
Yeah.
coach for different life circumstances. Again, I don't think that's super innovative, but I think that's super important. And I think it's something that, like, these kind of traditional models, and we're innovating around traditional models. That's where I see kind of when you have better access and you have kind of better frameworks. I used to give clients like worksheets and they would come back blank. I mean, I don't complete worksheets. I shouldn't expect other people to, but you can do a self-led journey on your phone. It's great. You pull it out when you
Yeah.
need to. And it's not
Yep.
access. You're not accessing therapy. You're asking like support skills. So that's where I'm seeing some of this innovation. Um, Kind of moving the needle a little bit beyond traditional one-to-one therapy and looking at what are care companions, what does peer-to-peer support look like, but also on the clinical side, what does their kind of clinical toolkit look like, and what support and what innovation is being made and developed to support them. So I think all three of those is what I see, what I'm excited by. Um, but I'm sure a lot of people, probably it's less sexy than a couple kind of models that are coming out.
I mean, I think that there is huge value in digitizing previously very analog processes like the
Yeah,
worksheet that you might be given. And I think by digitizing them, you usually increase access to them as well,
yeah.
which has benefits to anyone who needs it.
Yeah, no, absolutely. Gamification, especially for kids, is
Yes.
phenomenal. So mental health literacy through gamification, amazing. I was at a conference speaking about youth mental health, and someone in the room randomly has a voice agent, and they are, I can't remember specifically, but they work in one of the, oh gosh, now I can't even remember, but like one of the large video games, and they work on two voice identification, like they two specific mental health and kind of safety concerns too. But it was something that I was like, oh, you're collecting data and you can actually like I don't know how it works, but they're like logging into the video game and monitoring this and, kind of
Sure.
safeguarding that way. And I was like, oh, that's kind of cool. I don't really understand video game world, but in my mind, like that seems like innovative.
Yeah, absolutely. Very cool. Very cool.
So
Well,
yeah,
I really, really appreciate your insights and the conversation that we had today. You have done some extremely important work that is not for the faint of heart. And I think your journey, which is very unique and untraditional, is a really great example for others to let your heart lead you and listen to your gut of what it's telling you the important problems to tackle are. So thanks for sharing your journey, thanks for sharing some good insights and some market analysis of where we might be headed next. I really appreciate it.
thank you so much. I appreciate this opportunity. But can I just like tack on one last thing?
Please do.
Just like, when I got doged in January, and like global mental health did not collapse, but narrowed quite considerably. And when I was kind of looking at and figuring out how to lean in, I started off with a US healthcare network of almost zero. And I will say, kind of what we were talking about earlier, the thing that helped me the most is plugging into the networks, the events, the Slack groups. And that's where really, I mean, there was the motivation, but I also needed access to a network and I didn't know where to start. And I really think having looked and like, quite frankly, be told about those groups is kind of what started my journey and what kind of led me to different positions, different roles, but understanding the ecosystem and seeing where I could use my previous skills going forward. So I would highly recommend that. It worked for me, maybe not for everyone, but I did appreciate those insights that other people gave me.
Definitely. I mean, that's where we got connected first and foremost. So that is proof in and of itself that it is totally valuable to seek out, communities of people with similar interests or just the similar interest of thinking outside the box and doing this important work.
Yeah, absolutely.
So totally agreed. Thanks for that.
Thanks, Kayla. I appreciated our time.
Well, absolutely. If any of the listeners want to get connected with you or reach out or have maybe further follow-up questions or want to use you as a resource to tackle some of these problems, where can they find you?
I'm really only on LinkedIn and I only have like 4 posts. So that's something I'm also building my community, my brand. But find me on LinkedIn. Otherwise, I am on Instagram, but I have 6 pictures over the last 10 years. So I like to look, but not post. So LinkedIn is it is the only way to get in touch with me.
Perfect.
Thank you.
And I will put in your link to your LinkedIn so that the listeners can find you and reach out to you.
Sounds great.
All right. And if you want to get in touch with me, I'm also on LinkedIn, on Instagram at its.kla.b. Thanks for listening to another episode of Corporate Espionage. We're really happy to have you. Tune in for a weekly discussion of clinicians doing really awesome, non-traditional things. They're pushing the boundaries of what we expect clinicians to be doing in the space of behavioral health, of typical medicine. And be sure to like and subscribe wherever you get podcasts and tune in for next week's episode. Thanks again for listening, and we will see you soon.